It's a wonderful topic that has been chosen by Chitra, and it's been so beautifully done up by each one of the speakers just before me. And the onus of talking about surgery lies with me. And the two commonest types of surgery, augmented trabeculectomy versus the aqueous drainage devices. Does the buck stop here really? I don't know. Now, if we were to look at the pros and cons of both the diseases, let's have a look at it. There was a survey which was done between 109 glaucoma specialists and 130 retina specialists, because there is no consensus as yet on NVG management. The best thing was that there was agreement between both the subspecialties on the use of anti-VEGF, which Dr. Nirula has so beautifully talked about. This was the first kind of treatment. But I also feel that, PRP is absolutely essential. We have saved so many eyes by just these two things. And along with that, glaucoma surgery. And all the glaucoma specialists at each stage of the questionnaire that was put forward, the survey that was put forward, they all voted for surgery hands down. Problem with this particular disease is that the success is very poor. And we have to know, when do we operate? Do we operate in the open angle stage? No, we generally won't be able to control the pressure since we have already put the anti-VEGFs and done the PRP. So we have to do surgery when there's insufficient intraocular pressure control, despite giving maximum medical therapy. There's also this extensive, that means he's already gone into the person has already gone into the angle closure stage. And there's extensive peripheral anterior synechia that occludes the ankle and prevents aqueous flow. The three commonest methods by which treatment is given by surgery is trabeculectomy, aqueous drainage devices, and cyclodestructive procedures. But since the buck has stopped between the two of them, trabeculectomy and aqueous, I will only discuss these two. Now, you will just say, why do we choose trabeculectomy? See, trabeculectomy is very easily performed by all surgeons. We start teaching it very, very early. When they are postgraduates, they see it, and their fellows, they learn it. Simple instrumentation, minimal complications are there. No, minimal, I'll not say minimal. They can be maximal if it is not done properly and not looked after. It has also replicable, and it has a very short learning curve. Reliable, relatively predictable in hands which have done repeated trabeculectomies. We know that this is the stage where we can sort of control it, and this is the way we can look after by doing the surgery the correct way. And it has practically a straightforward technique. It's pretty cost effective also. Plus in India, even primary trabeculectomies are being done because people come so late to us. They do not adhere to various treatments, and the economics of it. Most important is economics. And therefore, when a poll was conducted, even in the GSI meeting in 2000, most of the glaucoma specialists, not primarily for NVG, but as such for all glaucoma surgeries, voted for trabeculectomy with the concurrent use of MMC, mitomycin C. Without mitomycin C, the chances of failure are very high, and we only think about twice in cases of JOAG or in cases of high myopia, where MMC we will be very chary of putting. Now, again, trabeculectomy, in case the people have already done a PRP, already done an anti-VEGF, then why should we go ahead and do it? Now, let's have a look at this surgical technique. As I have said, that it has been refined over so many years. Just a minute, I'm trying to remove this from my box so that my surgery, I can show you surgery. This particular surgery has been done by Dr. Vinay Gupta, and it's a beautiful surgery. That's why I put it over here. What is very important is that we must remember to put our releasable sutures, adjustable sutures, learn when to do the suture analysis properly. And very important is that we must not do too much of cautery, and yet do just adequate cautery so that our delineation is very, very good. Addition of anti-metabolites, it's been found that 55% of success rate in the mean follow-up of 35 months with the use of post-operative 5-uracil, fluorouracil, which I don't use. And most people have stopped using, most people use mitomycin, and success of 54. That means practically both of them, that is mitomycin and 5-fluorouracil, when used correctly, we find that the results are pretty good. And very important is the application of more field-safe surgical technique. Go posteriorly as much as possible. Take your mitomycin sponges as far as possible, go behind. and also the use of anti-VEGFs. Now, these anti-VEGFs can be given intracamerally or we can give it even subconjunctivally. Mind you, that these anti-VEGFs, which has not been touched upon, that we can, rather touched upon by Dr. Ritesh, that we not only use it during trabeculectomy or rather before trabeculectomy, but we also do it for in case our blebs are failing. And this has been, we have found that it gives extremely good results. We can also do by Elgin and all, et al. Before probably these anti-VEGFs had come into the scene, they were also doing cautery of the peripheral part of the iris because of the immense problem of bleeding which occurs in NVG cases. Now, even collagen implants have been tried along with that subscleral amniotic membrane. In the photograph that I have shown out here, this is the thin amniotic membrane which I have placed on the patient subsclera, and then this prevents a lot of fibrosis which takes place. Again, the releasable sutures, I put the Wilson sutures, and with this quadrangle sutures that we put, we find that you can take it out at the slit lamp whenever you want. You can titrate the intraocular pressure so well by means of these sutures. You can put any type of releasable sutures which works well in your hand. In my hands, this works extremely well. Now, what about intraocular pressure control with trabeculectomy? You know, in a very good study which has been quoted practically everywhere by Patyal and all, and he said that trabeculectomy with mitomycin C for intraocular pressure lowering in NVG eyes, success of, he is quoted a success of 62.6% at 1 year. This declines to 51.7% for 5 years. But they had done it in NVG cases with secondary to diabetic retinopathy. And one has to remember that it's very difficult to say that, okay, this case will succeed and this will not, despite doing a very, very good track. Now, what are the, causes, what are the causes of failure, and what preventive measures can be taken in order to save our trab and help the patient? Because the biggest problem is hyphema, bleeding during surgery. Now, this pre-op bevacizumab, it decreases the post-operative hyphema. It improves the success of trabeculectomy with mitomycin C, even up to 95% of cases. And it can be used pre-operatively, intraoperatively, post-operatively. And not only for a trab, it can be used, as I said, for failing trabs, even during bleb revision. And again, we can go by all the three methods: intracameral, intravitreal, subconjunctival. And it has been done by all of us, and we know that it works extremely well. Because when we have an eye which has got less of NVI, and with that also reduced intraocular pressure, by means of giving anti-VEGFs, we find that before the trabeculectomy, it definitely improves our success rate. If you would put good pre-placed sutures, because mind you, once the bleeding starts, if you don't have sutures in time, if you put the pre-placed sutures, it helps you so much to quickly suture the wound and prevent the bleeding. Even intraoperative sodium hyaluronate, just put it in where the bleeding is taking place, and then you find suddenly it avoids that sudden decompression, which leads to intraoperative bleeding. Because the moment your eye is so firm with the high intraocular pressure, you make a hole into it in order to go for the trabeculectomy, and there's sudden decompression, and you find the whole eye is flooded with blood, and you wonder where the blood has come from. It's happened to me, so I know what happens. Now, you must use releasable sutures and must release the suture, laser suturalizers at the appropriate time. Doing it too early or too late is not, it's not helpful. Therefore, these patients must be called, more earlier in order to titrate the wound and know when to do the suturalizers. And you can also use this 5FU or MMC. I have used MMC post-operatively in order on the bleb itself by means of a sponge, so that we can decrease the amount of vascularization. Now, there was another condition, the Liu and all, they have looked at, two types of patients. One was combined trabeculectomy with ranibizumab, and the AGV group, that is the Ahmed glaucoma valve group. 11 eyes of both of them, they achieved full success. In cases of the AGV group, on one hand, we found that 6 eyes failed, and complications were more, especially in the early post-operative period. Mind you, hypotony is a very big problem. All of us, when we are doing our AGVs, we always put in sodium hyaluronate into the anterior chamber, so that that sudden drop or hypotony which occurs in AGV can be obviated. And we can have a shallow chamber as well as hyphema. This, of course, is not been seen by every other, let's say, researcher, but this particular paper has talked about this particular problem that occurs more in AGV than in TRABs. But TRAB don't think it is very simple. A TRAB can have huge complications like bleb leaps and infections, blebitis, endophthalmitis, and it is not in the immediate post-operative period. Years later, the patient may come here and then he lands up with an endophthalmitis because of the infection that is there. You can have hypotony and hypotenuse maculopathy when you get to see them, and these are vision threatening complications. So one has to be extremely careful and learn to manage these cases very, very thoroughly. And of course, it has very bad prognosis when there's conjunctival scarring. Very important factor as I talked about is the economics of a particular surgery. You have a TRAB on one hand, and you have, let's say, the commonly used Ahmed glaucoma valve on the other hand. McPhee has found that in India, it is in New Delhi where the highest cost of a TRAB is about 34,000 rupees. But now just compare it with an AGV. The cost of just the valve is 26,000 rupees. Forget the rest of it, the surgical costs. And if we have the Aravind device that has come up, that has also a pretty steep learning curve, and not all of us are doing it. But that is very, very cost effective. It is only 5,000 rupees. But this is a non-valve device. What we are not considering is the cost of follow-up. Patient who has undergone a TRAB or a tube has to come for repeated follow-up. And the cost of medicines, mind you, it is not just the post-op of surgery, but also that you fact that you might require anti-glaucoma drugs, reoperation costs, bleb needling costs. All these are huge burden, financial burden on the patient. Now comes various valves that we are going to use. The commonly used valves, I'm going to talk about them, that is Marvelt and Ahmed. Now, these have come into increased use because of improvements in design and use of more biocompatible materials. But the greatest impetus to the use of the valves has been by the DVT study. Now, if we look at just the pros and cons of the what happens with trabeculectomy with MMC and tubes, one is that both of them show a pretty good reduction in intraocular pressure. We find that in tubes, definitely, we need to give extra anti-glaucoma medicines in the first 3 years of surgery. But again, after 3 years or so, you find that practically all of them become the same. The serious complications of vision loss, reoperation are practically the same after both the procedures, and no rate of vision loss after both the procedures after 3 years of follow-up. Cataract progression, of course, occurs in both of them. Now, let's say, why GDDs? Why? I'm saying that it is so expensive. So why should we go ahead and use a GDD? Low risk of infection. It's a very easy procedure. Look, the surgery that I'm doing, you've got to prime the valve, push the valve, create that pocket, push the valve inside, then suture the valve very nicely. I do it with 80 silk. And after that, measure the tube, where there's the tube going in, and then do not use very big gauge needles, preferable that, and then you allow it to be placed inside the anterior chamber, the tube that is, then cover the tube very well with the help of a preserved sclera. Even cornea will do, and that will help the patient, and that will also prevent some of the complications of the tubes. So the IOP lowering effect of these tubes is definitely maybe long lasting. It's a straightforward technique. It may be implanted and now with scarred conjunctiva. And this is where this particular tube is definitely wins over a trabeculectomy, where we are unable to get good success in trabeculectomy when we have scarred conjunctiva. And there are less bleb-related complications, and the patient also can use contact lenses post-operatively. But what are the deterrents to the use of these glaucoma drainage devices? One is the cost. And the tube-related complications, there can be corneal decompensation. I will show you certain pictures after this. There can be conjunctival erosion and tube retraction can occur. And in fact, in younger patients, we have seen that the tube just goes back. It can be implant exposure, tube retraction. In a case of AGV, we will have a hypertensive phase. Therefore, the patient has to be called back after 1 month or so, because we know that the pressures are going to rise. It may not decrease pressure as well as trabeculectomy. You might require supplemental medical therapy. And of course, sometimes we find that there's a huge cosmetic appearance concern regarding the bleb over the shunt, as well as the patch graft may be visible, which is very annoying to the patient. There can be motility disorders, hypotony in case of non-valve devices. There can also be, as I said, conjunctival erosion, encapsulation failure, cataract progression, vitreous hemorrhage, retinal detachment. And this is the picture of one of my patients who had an AGV, a tube, and you can see half the cornea was having a haze, almost corneal opacity. And this tube was not draining. And you can see that, the tube was, the entire plate could be seen. There was no blood at all. You can see the tube, the margins of the tube. Nothing was. Can I continue, please? Can I continue? And then this is of a patient who had the sclera had been thinned out and vortex had been placed, Dr. Abhininder Gupta. This is one thing that we have used. And 1.5 years post-op, we found that the results were extremely good and there was no exposure. Encysted bleb, this is in a child, 4 years old. And the iris may also get enmeshed in the tube, and along with that, it can touch the cornea and cause corneal opacities. We have to remember that success rates of GDDs and NVG are definitely lower in compared to other indications. And even if they do a PRP or concurrent use of anti-VEGFs, we find that it does not decrease. If we look at various studies, we find that 24 months has been the longest time and only 60% decrease of intraocular pressure. And therefore, you look at the success rate of AGV and you look at trabeculectomy with mitomycin, it's almost the same. And if you have a vitreous hemorrhage along with that and NVG, then we find that there's greater reduction of IOP with AGV over trabeculectomy in these cases. The Ahmed-Barveld comparison study, in which there was 29% of NVG eyes had been used, they found that the success rate was pretty almost the same. But very important is that the Barveld tube that has many more vision-threatening complications. Now, another express shunt which has been used also, this express shunt, we have used it long ago. Now it is no longer being used. And it's been used by people. Almost, the success rate is not all that good in these cases. And various other procedures like canaloplasty, trabectome, express shunts, but these are mainly for the open angle glaucomas, do not really succeed in the angle closure glaucomas. If you look at with the Ologen group, then in this case also, we find that it is not very, very effective. If you compare the 3 implants, AGV, Barveld, and the Keki Mehta implants also, there was not much significant difference amongst the 3 implants. So the question is, what should we use? I would prefer to go ahead, do a good PR. First of all, recognize the condition. To answer one question that Dr. Abhininder Gupta asked, and I would like to say this, we do not know, most of the patients do not know when they developed diabetes. So it is always better when the patient first comes, do an undilated thorough examination. Forget whether the patient, how long was the patient's duration of diabetes. And after that, go ahead and do a thorough examination of the for NBI. Search brilliantly for definitely for NBI. Do a good conioscopy and do repeated conioscopies. And therefore, I would prefer to do get a PRP done, and then after that, an anti-VEGF, and go ahead and do a trabeculectomy. If that goes in for failure, try to revive the bleb, and then go for an GGD. Thank you so much.